afternoon and welcome to the Aspen PSPS webinar on how to survive and then thrive, focusing on business strategies post-COVID-19. So excited you've joined us for the webinar this afternoon. We will start promptly at 5:02 to allow a few more people to join on. Thank you. The webinar will begin momentarily. Good afternoon and welcome to the Aspen PSPS webinar on how to survive then thrive with business strategies post-COVID-19. We are so excited you've joined us this afternoon. The webinar will begin in approximately 30 seconds to allow a few more people time to log on. Thank you, and the webinar will begin momentarily. Good afternoon and welcome to the Aspen PSPS webinar on how to survive then thrive, focusing on business strategies post-COVID-19. Thank you so much for joining the webinar this afternoon. I would like to introduce our moderators for this afternoon's webinar, Dr. Timothy Deere and Dr. Krishnan Chakravarthy. Gentlemen, take it away.
Well, thank you, Michelle, and certainly thank you everyone for joining us. I was just with Dr. Chakravarthy on an Australian webinar yesterday, but we weren't in Australia, but people thought we were. So, I saw a poll today that 30% of people still are enjoying webinars a great deal, where 70% are enjoying them only moderately because there's been so many webinars. But today is unique. This is a very unique webinar, and so those who are joining us, I think you'll find great value. And at the very end of this webinar, Scott Becker will come on and talk about some of the real pearls to getting your business back on track. And, you know, I think that's important. Krishnan, what's some of your thoughts on this session today?
Yeah, no, it's been a lot of fun moderating this with Tim over the course of the last 4 to 5 weeks, and looking forward to, I think this is especially important given everybody's kind of starting to edge back into practice. So, you know, I think we've got a great panel of folks today, and just looking to hear their opinion, looking to kind of share that with you guys through this medium. So I guess we can start with our first panel.
Our first panel will be up, and you know, certainly there's a big storm on the East Coast. So I know half our faculty will be impacted by the storm. So if we lose someone, it's just to be like picking up the flag. We're going to continue on. So Dr. Chakravarthy, take it away with the first panel.
Yeah, so you know, this group is special because I think a lot of the folks that you're going to see on this panel have done really well in terms of, you know, what we affectionately coin as young guns at our Aspen meetings, primarily because they've really come out of their practices, been really successful in developing a lot of the interventional procedures. So Alex, who's a close friend of mine, Sachi, Jay, and Navdeep, they've all really blossomed over the course of the first 2 years. So I think from their perspective, hearing for solo practices that have time of crisis, what they've done, how they've really strategized in terms of getting funding to keep their practices going, and what measures they're kind of taking to open up their practices, I think is really going to be interesting. So I'm going to welcome all 4 of them to kind of present a little bit of their thoughts, and then Tim and I are going to ask you guys some questions.
So who's going first on your thoughts here? Who's the first person up?
I'll go for it, guys. So thank you. It's specifically really exciting. And I've been absolutely enthusiastic about re-engaging with my patients again. You know, spent the last 5 to 6 weeks really implementing various changes. Our clinic was very quick to adopt rolling out using a telemedicine platform that I had to specifically be aware that my older patients could adopt here in Florida as well. The last 2 weeks now has been specifically just about adapting to the new norm and learning to make further changes now to thrive, not just survive. With that in mind, I'm sure that the other panelists, Jay and Alex, are going to talk about what we've done, but specifically, I'm just trying to figure out how we can get back into the clinic, how we can capitalize on what we learned with telemedicine, working on implementing social distance check-in process with our EMR system, revising our screening protocol with temperature checks, PPE strategies for patient staff, sanitization strategy. But we've all kind of, tried to tailor our clinic schedule with telemedicine and face-to-face encounters, restructuring timing. And now it's all about, the potential clinic plan for a procedural ramp up. We're excited to take care of our patients and just make sure we tackle it in a phased encounter.
So I just want to go back to what you said, Navdeep, and that's very interesting. So you talked about bringing telemedicine in, and I brought telemedicine in the first week of my practice. And now the question I have for Jay and Alex, and Sashi, I think, is on here, but her video is not working because of the storm. What are you going to do with telemedicine now that we're going to get back? I did elective procedures today, the first day back for me. What are we going to do now with telemedicine now that we're back to a new normal? What's going to happen there? What's it going to look like? So, Alex, your thoughts, and then to Sashi or Jay.
Thanks, Tim. Happy to be here with all you guys. Hope you can hear me okay. We're really excited to continue to implement telemedicine. I think virtual visits are here to stay, and we can show that we can still engage our patients and reassure them. Ultimately, I think a majority of our patients have felt abandoned. Their own primary providers have been, hit drastically on the front lines. And so I've had to actually refill certain medications, particularly blood pressure medications that they just weren't able to fill. I think the opportunity to re-engage a lot of patients within our practice is something that has been advantageous. I myself have found that my patient care has actually improved with this time to actually sit and go through a lot of the patients that I've failed to see. So being now almost 3 years out of practice, seeing, implants or stimulators that I did 3 years ago where I haven't seen that patient in quite some time, and to hear they're doing well and to give them the reassurance that we will be there for them. One of the things that we were talking about with Jay is utilizing this time to really offer patients the opportunity to witness some of the procedures and some of the things we can offer them during their virtual check-in. So a lot of patients are logging in early, and that time is an opportunity to really, engage them with content that they can see while they wait. What do you think about that, Jay?
I think that's absolutely right on the ball. Our practice, we're in New Jersey. I'm about a year and a half into my practice, and we're obviously hit harder than most parts of the country, one of the highest in the country. So telemedicine is something that we adapted now. We're coming on almost 7 weeks. We were probably one of the first in our area. We adapted very quickly. Our patients were surprisingly responsive. Everyone talks about the new normal. There's tremendous opportunity with any type of disaster situation like this. And I think as interventionalists, this is a huge opportunity for us, as well as our ancillary staff, to really just increase the efficiency of our office. The new normal, really pushing forward after all this is done in terms of the Thrive, which is what this webinar is all about. I really think that there's a tremendous opportunity utilizing telemedicine in terms of patient education tools, things like screen share opportunities. I've been able to explain things in a way that are so much more interactive with a lot of my patients in terms of procedurally. I know Tim in West Virginia uses a whiteboard, and this is almost like a digital whiteboard, and it's phenomenal. And it's actually been very, very helpful in terms of getting the point across in terms of the anatomic structures we're going to be targeting. Other things just from the solo private practice perspective, I know that the larger panelists, private practice panelists, are going to be speaking in a moment. Staying lean and trying to keep the overhead down is a huge thing at this time. And I think not just telemedicine, but other technological implementations in the practice can really help to do that, to keep costs down and to minimize the overhead that we have.
So let me ask a question. I mean, if I had to pick 4 of the best young guns in the world, it would be you 3, and Sashi's video camera is out right now. Sashi, can you hear me okay?
I can. Can you hear me?
I can. So let me ask Dr. Patel a question here. So Sashi, if you think about, like right now we have a big backlog of patients who we've been in delay, right? And so you're a small practice, and you have to get those people treated effectively. How do you manage that? How do you get people back on the surgery schedule for STEM trials and DRG trials, and spacers and MALD and all those things? What's your plan to really manage that?
Well, it's multifactorial. First is the patient willing, when it comes time to reopening, especially with coordination with the surgical centers, the first half of it is the patient feeling safe and willing to undergo the procedure. And if they are, the second half of the battle becomes trying to get block time in the surgical center when the urologists and the GI doctors and other ortho spine guys and joint guys want to share that space. And I think within the surgical center itself, we're trying to work out collaboratively, and we haven't completely defined this yet as to how we're going to prioritize certain cases. I do know that in order to minimize risk of transmission of COVID-19, we're talking about testing prior to bringing these patients into the ASC, as well as from the pain side, prioritizing more prone cases than supine cases, because it then minimizes aerosolization, of potential asymptomatic carriers. But right now, for me, part of the challenge will be first encouraging patients to feel safe to come through the door. Second, to make sure the ASC structure is consistent with the guidelines that everybody's following nationally, which is 6 feet of distance, sterilization, sanitation, appropriate PPE, as well as working with the remainder of the ASC staff and physicians to try to create a fair block time in getting all these patients in.
So, the four of you said so many important things. And I just want to point out, one of the other societies came out with some very prescriptive things in the past few days, and they've had to go back and correct some of those because they don't match everywhere. So I love what you said about testing. Like, for example, I do all my DRGs under general anesthesia with neuromonitoring. I'd love to have all those people tested before they get a intubation, right? But I'm not sure I'll be able to get testing done here. That's going to be a real issue. So I do think one of the things is going to be localization of where you are in the country. And for example, Jay's in New Jersey and Navdeep's in Florida and Alex is in Toledo. And Sasha, you're there in the tri-state area of New York, New Jersey. I think it's going to be very regional. I know we only have a few minutes left on this panel. Krishnan, any thoughts on that?
Yeah, no, I think you bring up a good point. I mean, it's not, I think region is one part of it. And the other part is I hear a lot of smaller practices say, how do we have the resources to really be able to do large scale and broad scale testing? So have you guys had any strategies on mid-levels and or testing in terms of prioritizing who's working, who's not working, anything that's worked well for you, especially the smaller solo practices?
I've actually had the opposite experience to Dr. Patel in terms of reinstilling confidence in my patients. They're knocking at the door constantly, just waiting to get their procedures done. So what we've done is implemented, specific days, and I think site of service is probably the most important aspect of what we're doing. If we are apart from the hospital and in no direct contact with what we call COVID care centers, then we can, feel a little more confident that we are going to be able to safely offer patients interventions. One thing in Ohio that they stressed was the prioritizations of non-surgical care. So I think we're going to see an increase in the number of patients that we'll be able to take care of and offer them minimally invasive interventions that don't require general anesthesia. As far as testing goes, Krishnan, go ahead. As far as testing, I think that is going to be something that we'll see evolve. It's a fluid situation that it would be ideal if we could test everyone. I saw recently that Quest Labs and LabCorp now have tests that you can order on your own for $119. If we can get the resources in the people's hands, then testing is going to be imperative. But unfortunately, right now, we're limited as it is for the people that need it most. And therefore, we have to continue to treat our population.
Thank you, guys. Tim?
I think, well, thank you all for joining us. I want to echo one thing about Sashi before it's time to leave this panel, and the four of you have been amazing. I want to echo one of the things Sashi said, though, and that's about the supine patient. That is much higher risk to you. I read some data today from over in Spain, and the supine patient for a procedure is much higher risk to all of us. But also, if you do an intubation, it's 15 to 30 minutes that this aerosol is in the room. So you may want to think about wearing goggles if you're going to intubate your patient and do a procedure under general. May be very important. Just a couple of thoughts. So I think it's time for our next panel. I thank the four of you very much for joining us. Sashi, I'm sorry your video couldn't join us, but I know you're in a storm there, and thank you for coming on.
Thank you for having me.
Thanks, guys.
Thank you.
All right. So I think Tim would probably do more justice in introducing these folks, but these doctors are actually, leaders respectively in different parts of the country, and household names for all of us. And so really excited to have Dr. Amir Delfan, Dr. Davis, and Dr. Lee kind of presenting a different perspective from a smaller practice, solo practice, to larger practices. And I think you're going to appreciate a little bit of the aspects of keeping a business running and reopening in this time. And I think the suggestions that they're going to be certainly giving us is going to be valuable for wherever you are. I think one of the questions that came up is for folks that are starting newer practices, what should they be looking for after COVID-19? So we're going to start with Dr. Lee. I think he's got a few slides to present to us, and then Dr. Gier and I will ask you guys some questions.
Okay, well, thank you very much, Krish. And I wanted to commend your leadership through PSPS, as well as Tim's and Dawood's leadership through Aspen, and taking the initiative and acting like beacons in a storm. How fitting, we're having a big storm on the East Coast for all these practices. So if we can use the same analogy, our practice is kind of like a cargo ship in the storm. We have to make small adjustments, and they take a long time for the ship to turn. So I belong to a large private equity owned or backed pain practice that's throughout the East Coast. And when we heard of the pandemic coming in from Asia during January, when we're all at NANS, we wanted to make some drastic decisions. So I wanted to share with you today in terms of how a large practice prepare and survive through such a storm. And I'll hand it off to my esteemed colleagues to talk about how we're doing now and what the image of, or the landscape will look like as we emerge from this pandemic. So as I said earlier, we anticipated this to be clearly a global disruption and a disruption to our practice. So early on, our practice, through the leadership of our CEO, Doug Weiser, and our CMO, Dr. Peter Statz, we initiated or assembled a COVID-19 task force to expect major disruptions to both clinical as well as economic impact to our practice. Our main goal is to maintain communication with our patients as well as our team, and we've done that. So through rapid deployment of telemedicine, we wanted to make drastic decisions in terms of cost reduction, in terms of economic planning, and in terms of clinical practice, we wanted to ensure patient safety, staff safety, and preserve access to our patients. So here's a little glimpse into what we actually did. Next slide, please. And these were very, painful, decisive decisions. I mean, humbly to say that I lost 8 of my long-term staff members. We had to reduce our overall national sales team. There was a reduction of full-time employees in the hundreds, including physicians and advanced practice providers. We all took salary cuts, deferred bonuses, and renegotiated contracts, essentially limiting our cash flow so that we ensure the survival of our practice. That included applying for government loans and relief packages and hiring freeze. So with that said, we were able to survive and hopefully weather the storm and emerge. I know New Jersey is still under the storm right now. So Kaz, I know you guys in California are also in a hot spot in a large practice. Are you doing similar things?
Yeah, thank you for that, Sean. That was really informative. As you know, our practice is slightly larger than, slightly smaller than yours, and we're privately owned, but we have a lot of the same issues. On the West Coast, just as a way of background, our group, IPM Medical Group, has 18 offices, 74 healthcare providers, and shutting down the organization wasn't really all that difficult. Almost overnight, we decided to go to telemedicine. We shut down all the offices. We only kept a very skeleton amount of employees inside the offices. We were lucky enough to be able to keep all of our employees and reassign certain ones to other tasks that were not patient related, so they could just work from home. And all the healthcare providers went to telemedicine. So we were able to work out the kinks with that, and it's been running really smoothly. But now we're looking at reopening the entire practice, and that's a daunting task. It's actually quite challenging. And we put together a very comprehensive standard operating procedure on how we're going to go back into this. We've thought that it's going to be a lot easier for us to open the smaller offices first. So we're actually opening the smaller offices of the 18 offices the very first week, which is the second week of May. And all the employees will be wearing N95 masks and gloves. We're going to give them enough masks for them to be able to keep them and use a mask per day and put it back in a Ziploc bag and use it again the next week. And this way we can save protective personal equipment for the entire country. And so they can continue to use it. And the idea behind that is that the virus dies within a week on those masks if they are contaminated. Only the employees who are at low risk in terms of age, in terms of their immune system, in terms of their underlying conditions, are going to be able to actually come back to work. And it's going to be only the healthcare providers and the skeleton crew that we need to be here for us to be able to see the patients. For the patient triage portion, we're actually going to set up stations outside of every single office. We're going to have no-touch thermometers to check their temperature. And we've decided to have 3 different essences for the patients to smell. Right now, we're thinking about almond, peppermint, and vanilla. And the patients will need to recognize at least 2 of the 3, and their temperature needs to be normal before they can enter the office. None of the family members or caretakers are going to be allowed to come into the office at all. In fact, for our waiting rooms, we've made some modifications for social distancing, but we're only going to bring the patients in, and we're going to try to triage the patients back into the exam rooms as fast as we can. The healthcare provider will be the only person who's going to see the patient. The scribes will not be allowed into the exam rooms at this point. The scribes may come to work and actually do the work that they need to do on the computers outside of the exam rooms, but they will not be allowed to have any type of contact with the patients as well. We've installed.
So Kaz, I just want to ask you a question. I want to interrupt you for a second. I think it's important.
Please.
Two things. Number one is, why do you want to bring them to your office? I'm asking both these questions. I'm going to get off and let you talk. But why do you want to bring them to your office? I mean, we're doing pretty well with telehealth, and we've decided to maintain telehealth till August here in our office without bringing anybody here except for procedures. And then 2 is, how do you really decide? You talked about your age of your staff. If they're older, high risk, you won't let them come in. How do you stratify your staff? Because they may be diabetic and have lung disease, but they may want to work. So how are you going to enforce that in a large practice?
Okay, so let me answer your first question first. Based on everything that the young gun said, we are actually adhering to that mantra. Telemedicine is here to stay. We're not doing away with that. Most of the patients are still going to be seen via telemedicine, even when we open up. There's a certain group of patients that we have to see in person. Those patients are the patients who really need a physical examination based on the findings that we have via telemedicine. New patients really need to be interviewed and examined by the healthcare provider before they actually enter the system. High-risk patients who may be on higher opioid dosages and things like that. In-office injections, patients who really need necessary injections to be done need to come to the office. And last but not least, our organization does a lot of med legal work, and those med legal evaluations need to be done in person. The rest of the patients, the maintenance patients, will all have to be seen via telemedicine. As far as the staff is concerned, as I said, we've been lucky enough not to lay anybody off, and we've reassigned to them the employees to do other things. And if they're deemed to be high risk by our human resources department, they will continue to do at-home work, and they will work on the assignments that they've been assigned to at this point, and they will not be required to come in. We've been lucky enough to secure some funding from the government through the payroll protection program. So we from a cash standpoint, we've done well, and we should be able to keep all the employees on payroll and keep them assigned and help them to continue to work with us. So it's going to be a gradual process. You know, we're going to start with the smaller offices. We're going to learn from our mistakes as we get to the bigger offices. For example, my office here in Walnut Creek has 12 physicians and 11 nurse practitioners and physician assistants who work here. So in order for us to open, we really have to make sure that we've dotted all the I's and crossed all the T's before we open this particular office. But we're hoping that the month of May will be the transitional month before we get here. But the future is going to be really different. And in fact, Tim Davis and I and Sean were talking about this, and we think that telemedicine is here to stay. Tim, what do you think about all this?
Yeah. Thanks, guys. Thanks for having me on. You know, I don't want to say that I have like a post-apocalyptic perspective, but it's certainly not sunshine and rainbows. The layoffs, the furloughs, et cetera, that have been done to try to preserve cash, decrease the burn rate month over month since this started. We're being artificially propped up for a short period of time with some government subsidies. And I'm not saying we as just us, I say we as small businesses across the country. The issue is going to be is that money's going to run out. All right. You got 8 weeks to burn it. You got to prove that you used it for payroll, rent, you know, debt service, interest. But there's going to come a point in time where we are almost fully ramped back up, and the revenue, the AR has already dwindled down. So then the revenue is not coming in, but then you're going ahead and carrying payroll and full expenses for another 60 to 90 days. So this is almost as if you're starting a practice fresh again. The issue with keeping on personnel, look, not everybody's going to get their job back. That's the reality of this. And you know, it's a evolution, right? It's evolution at its finest and at its most devastating. You know, Ramo Naidu had said that, you know, you get change by either the carrot or the stick, by either incentivizing something to change or by beating it into someone. And this was Mother Nature beating this into us, reminding us that we're not in control. So you try to take control of the things you can do. You can cut your burn rate. You can preserve cash, as Sean was saying. A lot of the employees that we once did have may not actually end up coming back, because if we're smart about things, we're going to do things differently across the board. We're going to leverage technology. We're going to leverage software to try to do some of those tasks that maybe somebody else was doing. And if we're smart about this, and if we treat this as an opportunity to lean out, a forced opportunity to lean out, then I think it's going to make us a lot stronger coming out on the other side of this. Telemedicine is in my eyes, obviously here to stay. And people have now gotten almost accustomed to it, and they like the convenience of it. So if you're not offering it as part of your service lines that you're offering, your competitors are going to, and they're going to be just more convenient, and they're going to go there over you.
Yeah.
So let me ask one quick question, and then Dr. Chakrabarty, there's the next panel. The question for you guys, and it's a very quick question, brief question. Are practices going to survive out there in America? Are we going to see less pain practices than before? Will people close? Tim Davis, you said people are going to lose their job. Are doctors going to lose their job, or is that your thought?
Yeah, practices. Well, look, there's going to be an opportunity for private equity to roll up more practices, because it's not coming right now. The working capital crunch is going to come in about 3 months, maybe 2 months, somewhere around there, where people are really going to be strapped because they've been trying to maintain all their structures as they once were, yet the revenue hasn't built back up, because we don't know exactly how society is going to re-engage after this. What's that going to mean to our overall revenue? Because I can tell you that the virtual visits don't reimburse the same, right? And you don't need as much manpower to maintain those virtual visits. So there's two different factors there. If you try to maintain the same manpower, your cost hasn't changed, yet your revenue has drastically decreased because the reimbursement for each of those visits just isn't the same. So you're trying to maintain a model that now is broken and doesn't work and really doesn't have a place in the future. So in 2 or 3 months, I believe there's going to be a big opportunity for mergers, acquisitions, private equity roll-ups. And the question is it going to be by willing participants that actually want to do it, or is it going to be forced because they're in such a bad economic situation that they don't have a choice?
So, Tim, I think that's brilliant commentary, and we're Mr. Becker later. But Sean and Kaz, a real quick rebuttal on that, a real quick thought on that, and then we'll go forward.
You know, I think there's going to be casualties in this. Smaller groups that are already here of people having early retirements, just closing doors, not coming back. And I agree. I think this pandemic is really testing our limits of what is essential for our practices and what we can utilize in technology. So we're learning how to do this with much less staff. Kaz, are you seeing the same thing?
Yeah, there's 2 things. Safety in numbers. People are going to come together more and more, and we're just not going to need the kind of physical space that we've needed in the past to conduct clinical medicine, and that's all there is to it.
Great points. Thank you, gentlemen, for joining us. Thank you so much. It was a great discussion. Tim has suppressed me now, so we'll go forward. So, Krishnan,
you're welcome. You're welcome.
Yeah. So the last panel actually is probably very relevant on my end, especially as a practicing clinician at UCSD, and I think a totally different set of challenges in a large academic center, whether it's prioritizing cases to deciding, having the resources for testing and a lot of the triaging, but what we actually finally decide. And I can tell you a lot of the folks that are probably on this panel are also dealing with multiple different departments and trying to voice their need to put their patients first over others, especially. I can tell you that's a tough challenge within UCSD. So I'm going to turn it over to Dr. Kalia, Dr. Pare, and Dr. Syed, and just kind of give your respective experiences. I know within Kansas, UCSF, and Rochester, have a little bit of a sense on different parts of the country, but yeah, what you guys are dealing with from an academic perspective and the challenge of reopening.
Yeah, I can go first. So first of all, thanks Tim, Krishnan, and Dawood for all your leadership during this public health crisis. I think all the work which you guys put in, especially coming up with the newsletter, the task force, the webinars, and all the position papers were really, really, really helpful for all of us in this field. I think I can speak for a community-based academic health system. So I'm part of a community-based health system, and the challenges which we are seeing are similar to some of the really big academic university settings as well. But our challenges are unique in a way, in certain senses. So my initial suggestion to everyone would be that when you're thinking about designing a comeback strategy from this crisis, the key will be to listen to your local public health department announcements, because what we have seen is the incidence rates, the prevalence rates, and the case fatality rates vary in all the different communities all across the country. And the duration of the social distancing and mitigation strategies which have been put out by the agencies also vary. So the strategic response will be dependent on these 2 key factors. Some of the key challenges which we are seeing in our community is obviously the multiple sites in our health system. We have about 5 hospitals with access to their operating rooms. We have 2 ASCs, and we also have the hospital-based outpatient departments as our practice areas. And to confound those and to make more things challenging there, we have multiple providers which are cross-covering those sites of services. And that makes a logistical nightmare to equitably distribute the times for providers to come back in this strategy of thriving and surviving after the pandemic. So we know that there are two different aspects of an interventional pain practice. You have your clinic part, and you also have your procedural part. I think with the advent of telemedicine, and I agree with all my colleagues, I think telemedicine is here to stay. And with advent of telemedicine and the face-to-face encounters, we will be able to achieve, if not 100% capacity to our clinic, but at least 75%. As far as procedures are concerned, that's going to be a big challenge because we won't be able to achieve our capacity because we'll have to comply with the social distancing guidelines and the mitigation strategies, which will slow us down and will decrease our efficiency and capacity and so forth. So some of the strategies which we came up in our region were kind of backed up by the data, first of all, because I think data-driven decisions are going to be the key to be successful from this pandemic. Some of the stuff which we came up with to do a phased approach to reopen our sites. The first phase included our urgent and urgent elective procedures. We are actually in the phase 2 now, where our local health department has allowed us to do the elective procedures. So we are going to be doing some elective cases starting next week. But the key will be to now strategically think about all the backlog, which is already there, and how we can not only clear that backlog, but think about other strategies to increase our efficiency from a procedural standpoint. And we'll probably have to think about looking into alternatives and explore options to increase procedural capacity as well. Extending hours, looking into working on a weekend, exploring or optimizing or even creating new additional fluoro suites. We have 2 remote hospitals which have smaller mini local rooms, and we have asked those operating rooms to give us those mini local rooms so that we can expand our footprint for procedures. Maybe think about doing some of the procedures under ultrasound guidance, obviously keeping the risk safety profile and the reimbursement in mind, and open up that procedure suite to clear the backlog and move forward. So, and obviously looking into exploring diversified revenue stream to maintain sustainability. I think in the end, this for most of us, the pandemic has been almost like a baptism in crisis management, and it has taught us a lot. And I think the future is going to be dependent on how we strategically plan coming back from this crisis, which should be data driven.
So let me take what you said, Hemant. Great point. I agree with everything you said. I think that really sets a tone. I want to add a complicated factor to this with Lawrence. Lawrence, I want to get to you and Dawood on this panel before we go to Mr. Becker, and that is you have fellows. You're educating people there in San Francisco. That's a very different. So Hemant and I are very similar in what we're doing. And everything you said is accurate, and I like everything you said. But what you have to add fellows to that now, Lawrence, in San Francisco. What other factors play a role?
So our training of our fellows and our residents has been a bit of a challenge. The clinic visits actually has not been too terrible. UCSF has been doing telemedicine for 5 years. I had about 10% of my patient visits being telemedicine before all of this happened. And overall, the university went from a 2.5% level of telemedicine in February to 55% in March, and we're probably pushing upwards of 70-something% now. And so the fellows and the residents are joining us for our telemedicine visits. As a matter of fact, they're running the interviews, and I'm there and we actually take a telemedicine break, do a little conference, and then go back into the telemedicine room with the patient, just like we would do in the clinic itself. So from that perspective, I think the training programs have been able to maintain that experience for the fellows. Of course, the procedures is another story. And of course, being the director of neuromodulation here at UCSF Pain Center, I'm most concerned about the amount of the amount of neuromodulation cases for those fellows who were doing their neuromodulation rotation starting in March and April. they certainly are going to take a hit. We have 5 fellows, and some of them do their rotation early in the year and get, a number of cases going. But those that are coming later are certainly suffering the consequences of that. And so, I'm not sure we can compensate for that so much, but those that are going out into the community or other institutions, I've already started to reach out to the places where they're getting jobs to try and get them mentors in the area so that they can continue their training, practical experience training if they didn't get enough during their fellowship. At the university, of course, we're taking a wide range of hits, 60% reduction in all our cases within the first couple of weeks. And while we prepped and got ready for the large surge that we were anticipating, it didn't happen. And so many of our faculty are actually traveling to New York or the Navajo Reservation to provide assistance in those locations. Many of our pain faculty are doing more visits with OR time and things of that nature, if they still kept up their anesthesia skills. So we're trying to compensate. We are a referral center for much of Northern California, and there's several hundred miles in each direction. And as a result of that, we're seeing patients who are coming from practices who are already starting to let go some of their pump patients and things of that nature. So we're trying to accommodate that as well. So it's been a bit of a struggle, and but I'm sure we'll come through. We're all already are all taking a salary cut across the board, and but are here for the sake of both the education as well as the care of our citizens of California. So we're in it for the long haul.
So I'm going to ask a question. I was going to give it to Krishna, but I really want to follow up on what you said, Lawrence, to Dawood, because I think it's important. So Dawood, last night, I'm building on what Lawrence just said, what Hemant said earlier. I was talking to some folks and I said, I told the fellows in January, I did a fellows program, and I said, 2020 is going to be a great year. And I said, but truly 2020 sucks. It's like the worst year of all time. So I guess the question for you is, for you academic minded people, how are you going to finish this group of fellows up to make them competent? And how are you going to help the new fellows coming in to get experiences? Because of all the things Lawrence and Hemant just pointed out as limitations. And then after that, we'll go to Mr. Becker.
Yeah, I mean, I think it's a challenge for this year's fellows. I've kind of said prior, our fellows are usually pretty blessed to get most of their cases very early on because we're pretty interventional. We've been using this time to kind of focus on other things, academic pursuits, where we typically wouldn't have that time. We're kind of busy seeing patients, so working on wrapping up clinical studies and things like that. I think my fellows have probably seen more webinars in the last month than any fellows have seen total in our whole program. So I think they're getting a lot of good outside learning. I think the hands-on exposure will still always be a struggle for them to kind of catch up with that. But I think they all kind of get, they'll all catch up within, they may just be a little bit further behind the curve than, fellows in prior years, but I think they'll all catch up. So I'm telling them not to worry. I think they're all going to get the piece of paper. They're going to be board certified pain physicians, and they'll catch up in the future. But I think, just coming from an academic practice, I think when you see what the other guys are struggling, we're struggling with things in a different manner. It's a lot of committee calls, and we're trying to balance things between other departments. Also looking at, what do the surgeons want to do? What do people within our own department want to do? I think early on in the course of this, we're also kind of having to deal with the reality that maybe some of the pain physicians would get pulled out of the pain clinics to go cover COVID patients in the ICUs, and trying to figure out how we were going to handle that scenario. Luckily, it hasn't gotten to that point. Who knows what the future will show. So I think, there are challenges in our standpoint. They're all significantly different. Now we find the challenge over the next few months is us wrestling with hospital administration to get more pain procedural time. They're always wanting to hold us back a little bit more and be very conservative where we're from. And we want to, of course, as interventionalists and surgeons, push the envelope a little further. And we don't have, as much authority as someone that's a solo practitioner that can essentially do what he wants to do. We have to kind of balance this with committees and CEOs of health systems. So those are the challenges that we're uniquely faced with.
I just have one real quick question and a comment. I think we focus a lot on filling the gap in fellow education, having their training shortchanged. there are a lot of fellows now that are getting a lot of anxiety where they've had jobs that have been reneged because of the inability for practices to hire. Is there strategies around your respective health systems to put them on an MSP contract, or any suggestions that have been made on a bigger level to try to give them some form of job security on graduation or anything of that sort?
I mean, for our two fellows, you know, they're both sitting in pretty good situations right now. So we haven't had to entertain those types of conversations. I can say I don't know what's going on across other departments and residencies and fellowship programs within our institution, but I'll defer to Lawrence. He has quite a few more fellows than us. I don't know if that's popped up with some of his future fellows or current.
Haven't heard of that from any of my fellows yet. They all have positions that they're planning on starting in August. So I hope that doesn't pan out to be the case, but so far they're all looking pretty good.
And I think Tim Davis is way too negative. I don't think it's going to be that bad, by the way.
So Himmat, any comment on that, Himmat?
Yeah, we are actually also hiring, a couple of fellows straight out of fellowship, and expanding our expansion plans and strategic plan is on the track.
Very good. And we're hiring as well. We hired one great physician, Dr. Allison Engel, and we got 3 interviews tomorrow. So we're definitely hiring as well. So I think there are going to be people out there hiring, and there's patients who need care. We have to care for folks, right? That's what we do. So thank you so much for this panel. Phenomenal job, everyone.
Thank you.
I heard I was asked to join just now. Was that right?
So Tim comes on for his rebuttal.
No, I'm going to wait for Scott to ask questions.
Okay, so Scott, we're gonna have Scott, then Tim will come on, Scott, and correct you probably. Scott Becker, actually, correct me if I'm wrong, Scott, but you're a Harvard-trained lawyer who runs the Becker Healthcare Report, which I read every week religiously. It's certainly a great report, and you really have helped us understand what's going on in the world of spine, the world of pain, and certainly it's a pleasure to introduce you tonight, and we look forward to your comments. So you have the floor for the rest of the webinar, and we'll come back for some questions.
Thank you very much. And before I get started, I want to thank you for having me. And also, Tim, I want to make sure my phone sounds clear, that the quality's okay.
I think it's very Chicago-ish. It's pretty good, but it's not great. But we'll take it because
okay.
It's pretty good.
Let me know if I need to. I could download it from another phone because we're having some cracking sound on it earlier on a Zoom call. So stop me if it starts to sound bad, and we'll dial right back in. We're going to touch on really 5 things today. Sort of generally what's going on in COVID-19, just real quickly. Impact on pain practices, ramping back up, some thoughts on society as a whole to open back up, and then other policy issues. And we'll do this in 10 to 12 minutes. So in terms of generally, and as was mentioned earlier, the impact of COVID-19, both on how it's hit different communities and how it's hit healthcare, has varied greatly throughout the country. What we're seeing internationally and so forth, and this will just be to sort of ramp into the discussion, is Europe is starting to look better. Spain, Italy, France, Germany improving. Parts of Europe getting back to work. And one of the important things to note is, and this is expected, if things start to open up, you're starting to see flare-ups and different infection rates start to grow a little bit. And we as a country sort of have to be prepared for that for some very significant period of time. It's not like a fire that's being put out. Rather, it's a fire where there'll be constant flare-ups here and throughout the rest of the world for probably a very long period of time. New York is through its worst part. A sort of positive, which is ironic, is that antibody tests are starting to show that a lot of people have had this already and already been exposed. And that weighs in multiple different ways, as you know better than I do. Lockdown has slowed down coronavirus, clearly hasn't killed it. You have to view this as a long-term fight, not a one and done. And the real death rates are still not very clear. It's somewhere between the 3 to 4% that some suggest versus the rates of 0.004% or so that may be based on true infected death rates. And the real death rates are ultimately quite important to making sound policy on precautions and how we treat this. The part of the country is starting to go back to work, which we'll talk about now. In terms of impact on pain practices, so background, things starting to get a little bit better throughout the world, and now talking about impact on pain practice over the last 4 to 6 weeks or so. The impact overall on pain practices has been devastating, and I think most of you would agree with that. I heard Dr. Davis's comments. I do think on a lot of it, he's quite right. Most practices essentially stopped procedures in mid-March or so. The procedures are the big cash driver for most practices. There's just not many ways around that. Cash flow, of course, follows practice. So you stop procedures in March 15th or so, cash continues to come in for 4 to 6 or 8 weeks after that. It's after you ramp up and as the PPP funds and other funds go away that practices really end up with really low cash flow for some period of time. So the cash flow will take a while to ramp back up, and AR to ramp back up once you get started. So it is probably 3 months from now, 2 to 4 months from now, even now as you get started, that cash flow is going to be really weak for some period of time until it starts to ramp back up. Telehealth, obviously fantastic for being able to consult with patients, has kept a lot of physicians busy. Practices that were doing 5% of their visits through telehealth are now doing 50, 60, 70% through telehealth. And they're not just doing existing patients. So remote assessments, prescribing's way up. The challenge with telehealth is it can keep practices very busy, but it's not nearly as profitable as procedures are. And we'll talk about that in a moment. The country, as you know, has made telehealth and writing prescriptions across states much easier. A few quick practice quotes. One practice said to me, revenue is at less than 10% of usual and customary. So that'll give you some sense. Another practice said, the naked fact is we are in deep economic trouble. And again, this may differ broadly whether you're at an academic medical center, you're at a large practice or a small practice, but these are some of the things that I've heard in talking to pain management practices. Another practice said, to continue for 60 more days without procedures would end my practice as it now stands. And just a few other notes on sort of what's been the impact. The impact's been dramatic in lots of practices. There are things that people talk about. Opioid prescribing is up. Behavioral health clinics are very busy. Pain management patients may be higher risk for COVID-19, which has some impact just overall. So we talked about so far generally what's going on in the world and where we're at, and the impact on pain practices, which has been relatively negative. And there may be some different stories, but largely that's what I get from talking to practices. In terms of ramping back up, 5 to 10 thoughts here. Many practices are starting to allow elective and non-essential procedures. There are some places in the country, usually outside of the major population centers, that were already doing some elective and non-essential procedures in terms of how they were judging it. But you have to be in relatively remote places for that to have continued pretty well. It will take a while to ramp back up and to generate cash flow. I do think that's a very, very real issue, that you're going to have some real cash troughs after the original AR runs down. Critical as you ramp back up, and everybody's talking about this, what prophylactic steps you're going to use to make your staff, yourselves, and your patients confident to come back in. This may be a lot easier in surgery centers and practice offices than in large health systems to deal with some of these prophylactic steps and patient confidence. What we've seen throughout the country is ventilators in pretty good shape at this point. PPE, very different from place to place. In some places, pretty good, and in a much better spot than it was a month ago. But even when I hear people talking about, we're going to have our staff use the same PPE for days, it's something people didn't really worry about before. And testing is still behind ventilators and PPE. In some places, testing has really caught up. The beauty of great testing is when testing is quick and rapid, it allows you to be much more cautious on your use of PPE, so you don't have to assume that every single patient is a COVID-19 patient. Other things that I'm hearing in terms of what's going on in practice ramping back up, rapid testing is the desire, masks for everybody, no family or friends, limited people in the waiting rooms, and a lot of improved communications technology to better monitor people coming in and out of the waiting room and into the facility. So more caution on crowds and waiting rooms. Good news is probably a lot of pent-up demand and easier to ramp back up in pain than some other specialties. And not entirely, but probably in general easier, quick procedures, in and out procedures. Cash will slowly start to pick back up, and then at some point in a few months, more quickly pick back up. It will take a while. As we've discussed before, patients may be more comfortable in ASC and practice office settings than in larger hospital settings, and we'll see how that goes. Pain is largely not self-pay and may not be as impacted by recession as some other specialties. And that's also probably good news longer term for pain practices. As someone said earlier, we're already seeing private equity funds. We have cash to deploy. That will be tougher for them, very much trying to look at, can they buy up practices that are in a moment of pain and really scared about cash flow. And we've seen some of that targeted at smaller practices. So recently a fund came to us, wants to buy 40 practices, small practices. This is in ophthalmology, but small practices that are really sort of can potentially be an economically challenging spot. But it can be the same thing for large practices. We've talked a lot to practices that are doing $10 million a month, $15 million a month, $200,000 a month in expenses, all quite concerned about their situation and financial situation. In terms of prophylactic steps, obviously at the end of the day, people have to follow closely, and this will be for legal purposes and all kinds of purposes, safety purposes, following CDC guidance and association guidance, try and reduce your exposure to plaintiffs' lawyers and trial lawyers and so forth. In practices, small, large, part of health systems, people are putting together governing rules, much as you were talking about, as to what kind of patients are coming back first and also what kind of prophylaxis you're going to use. So there's going to have to be some serious effort made in every practice to document and follow what your plans are going to be for ramping back up and what patients you're going to see first and how you're going to handle things and how you're going to handle things on a prophylactic side to try and lessen lawsuits from patients, employees, staff, and others. A lot of those issues. In terms of the fourth point of the discussion, which is on society ramping up as a whole, 5 or 6 points, and some of these we've discussed briefly. It seems like throughout most of the country, we're at the spot where there's been sufficient ventilators to meet the expected surges. And of course, many places, the surges did not come as big as they were expected, but that very well may be because of the large lockdowns and shelter-in-place rules. PPE is in far better place than it was a few weeks ago or a month or two ago, but as you really ramp up essential or elective and non-essential procedures, it'll still be tight in some places, clearly. We will need as a society a ton of testing to know who's possibly immune right now, who is sick, and what the real death rates are. And it's a discussion that has to be had, and it's a politically charged discussion, but the testing has to ramp up. If you could blame the federal response, not blame the federal response, the one thing that clearly has not been correct about the federal response, at least from my perception, is this concept that we have all the testing we need. I think nobody really feels like that, at least not in total. In some places, it's getting much better. So right or wrong about a lot of things, they've probably been wrong about the amount of testing that we have available and how much we need. And that's not a fault of the federal government other than what they've said. The reality is ramping up testing for 330 million people is very challenging, particularly for something new where you need different levels of PPE to even test people and you're trying to conserve PPE. The messaging's been horrible. The reality is it takes a while to get it ramped up to the right spot. Promise on vaccines and therapies, this is important for people's confidence that at some point we'll get back to a new normal. The challenge, of course, is this is not a short-term game, I don't believe. It's unlikely to be a silver bullet or a magic bullet. Prophylactics, we've talked about that, and I think you'll start to see the country slowly start to ramp up. Ironically, those places that didn't ramp down fully will ramp up more quickly and be healthier economically than other places. The last thing I'll touch on for 2 minutes is policy issues. Fascinating political discussion in our country. There's been a discussion in the last few years about free market versus Medicare versus public option, with a couple different comments. There are certain things in the Affordable Care Act, regardless of your political leanings, that people like. Certainly, by and large, everybody wants to get health care regardless of pre-existing conditions. Second, regardless of political leanings, more and more people like the concept of some sort of public option. Nobody likes to be held hostage in any state by one insurance plan. The third thing that I'll note is, with employment higher than it's been in a generation, this will prod more people towards entertaining and listening to non-free market alternatives. And free market's always sort of a mix, because in healthcare, as you know, more than 50% of healthcare now is Medicare and Medicaid and government programs. So we never have a true free market, but you do have this concept of, for a lot of practices, the commercial payments disproportionately pay the bill for practices. So a lot of practitioners are concerned about fully government-funded healthcare. But you will see a higher push towards it, because you are in a spot where, as a nation, you've got more people unemployed in a long time, and so much of healthcare is tied to employment. A couple other issues, and then I'll wrap up and pass it back to Dr. Deere, is as a nation and as states, there will be higher debt at every level because of COVID-19 and because of the slowdown of the economy. Higher taxes are likely coming. That's not on my end. Higher taxes are likely coming somehow or another. It's hard to see where they won't be, just because there's going to be a crazy amount of national and state debt. And that will lead to probably a slower national rebound and might place some caution on expanding Medicare, expanding a public option. But there is going to be a huge push for some of those things, and it'll be fascinating to see what happens this fall. And again, we've touched on sort of the impact on pain practices, ramping back up society as a whole, and policy issues. You've touched on, and a couple of you did a brilliant job of talking about some of the financial survival things that were done over the last several months to keep things healthy in your practice, at least going. But, you know, so we spent more time on the ramp up and what that's likely to look like. And I don't think it'll be as quick as people would like it to be, but I think it's going to be better in pain management than a lot of other specialties. So with that, Tim, let me pass it back to you.
Yeah, Scott, I actually have a question. I mean, I think a lot of folks, you know, we keep talking about ramping up. I don't know if you read the recent article from, you know, Dr. Fauci just mentioned on CNN, and there's a large number of ID experts who think that this is more of an 18 to 24 month effort in terms of getting through this whole process, especially in the fall, where you're going to see a spike of flu cases as well as the kind of the screening. Is there a certain sense on strategy, not just in terms of coming out of this in the next 2-3 months, but really planning on what should be the way we think about the fall time, so that we're not in a position where the next thing is again going back to a social distancing model, as opposed to having a very robust testing and contact tracing type of platform all across the country. I just worry that there's not enough emphasis necessarily on 3 to 6 months down the line in terms of both the financial, the kind of the opening up that people should be thinking about. I just want to get your thoughts.
Yeah, no, I think it's a great point. I mean, you've got this very, very challenging situation where you know, if we knew a vaccine was coming in 2-3 months, we might end up really just staying home for the next 2 to 3 months. The reality is, as we know in chasing an AIDS vaccine, as we know in chasing other vaccines, a vaccine might come in 12 months, it might come in 24 months. It may be like the flu vaccine, where it's helpful for some and not for others. You know, I don't think you could bank on the silver bullet. So I think what you're moving towards at some point, whether people like it or not, is something that's going to engage and involve social distancing for a long time of some sort, But I don't think as a society we'll be able to live with the draconian shelter in place for a long time. I just don't know how that's possible. So I think, like, as much as on the right and left, they try and bash countries that have not done the amount of social distancing that we've done here. Let me rephrase that. I mean, Dr. Burke says we're going to have social distancing for a long time. She said it through the summer. The reality is we're going to have social distancing till we really better understand this disease. But social distancing won't be as draconian as what we've had the last couple of months. I just don't think economically we can handle it. And I hope that the infection death rates ultimately show that the death rates are bad, but they're nowhere near as bad as originally contemplated. And so there will be different kinds of social distancing. I think what you're going to see, though, Dr. Chakravarti, to your point, though, and somebody said this earlier, practices will open in phases. They start to figure out what they're comfortable with and what works and what sort of works for their staff and for infection control. So you won't have, if you were doing X procedures a day on day one, or whatever the number was, 3 months ago or 5 months ago, you probably will be doing half that to begin with, or a lower amount to begin with, to really get a sense of comfort levels. I don't think our society can live with too many of these complete lockdowns for the long run. So it's trying to figure out long-term social distancing that makes sense, provide steps that make sense, and that's why the PPE, the testing, the prophylactics are so important, because ultimately I think we've got to find some middle ground.
So I know, Scott, we have a couple hundred people online with us, and I want to make sure we respect their time. I want to be done at 6:30. 23 minutes from now, we'll be done. So I want to ask you a question, and I want Dawood say to follow up your answer. And I feel like Chris just asked a Chris Cuomo type question to give you a chance to be very negative, as CNN does. And Sean Hannity's very positive, which is wrong. So I think both sides are kind of crazy. And I like what you said about being apolitical here. The question is, we had a really nice paper written recently on guidelines from Aspen about this problem. And Dawood and I decided not to publish it because we felt it was too fluid. It changes every single day. And that leads me to this question, because some people have given guidelines. What is the risk to the pain practice out there? We have, again, a lot of people here, if their employee gets sick and they go back and open up things wide open and the employee gets sick, or if they don't open up things and a patient commits suicide because they're in pain, what's the role of guidelines for societies, and what's the role of practices and the legal risk to them? I know you're an attorney, so I want to speak to legal risk, and I'll have Dawood talk a little bit about what Aspen's going to do.
Sure. No, it's a great question. You see this in the national news today and yesterday, where on one hand, the Senate, Mitch McConnell or somebody says you need immunity for businesses of some sort. And there's this great question, not just practices, colleges, schools, grade schools. If they open up and go back, are they setting themselves up for all kinds of lawsuits? So for example, if you're in almost any kind of business, you can't be the only one opening up, and you'd prefer some sort of immunity. Then the left says, well, this is really intended to harm worker rights, which really, I think that's a euphemism for, there's one side of the table that wants to protect trial lawyers, there's one side of the table that wants to protect business, and of course, the reality is the right answer is probably somewhere in between. I think what happens is, the standard right now is still negligence to get sued. So you go back into business, you have to be adhering, working towards lots of prophylactic steps. We've really never been in as a nation in exactly this situation. Certainly if you're a coal mine and you don't protect your coal miners in at least the standard of practice way, you got sued by your coal miners. And the same thing with OSHA and all kinds of worker situations. Here it's a little bit different because you got such an infectious virus, such an interesting situation, and you have this great divide of some employees don't want to go back to work because they're doing okay not at work, and because they're scared to go back to work, and some are vulnerable and shouldn't go back to work. So you've got this great divide of people that want to go back, don't want to go back. The legal issue right now, it's a big issue. It's if you're in the conference business like we are, you can't be one of the only people starting to put on conferences again because you can't afford the liability like Biogen. When Biogen got sued to the bejesus, and the government started investing Biogen for having a conference sort of at the beginning of the COVID-19 situation, we sort of knew at that point, well, that was the last shot for our April and May conferences and probably our June conferences. Then we've got to decide in the fall. But it's very similar for practices. When you'll have to adopt a whole number of protective steps, and unless there's some kind of immunity given, you do have some risk.
Yeah, I think those are all great points, Scott. I'm also interested in your question about when is the right time for a medical conference. And we could have another webinar on that potentially. Maybe this will be our new reality for these. I think we're supposed to have our think tank really at right when this whole thing kind of blew up. And I called Tim I think midnight his time. And I go, I think we're gonna have to cancel this thing. Look on TV right now. We made the decision to cancel it kind of last minute there. But as far as what we're going to do for our patients, and I think we do have to kind of worry about the legal ramifications, especially when societies put out big practice guidelines out there. I think what we all believe in Aspen is that we really can't be too prescriptive when we put these guidelines out there. If you put these tiers out there of different types of procedures that you should and should not do, obviously in different pockets and locations, there's going to be practices where that is probably totally reasonable to do. And when that gets into the hands of attorneys, if there's a bad outcome somewhere else, I think these guidelines can really be something that are used against physicians. So, Aspen is still taking the lead, and we want to provide guidance for, all the physicians and clinicians and patients out there. But really, I think the key is to not be overly prescriptive, to give them educational tools to use so they can provide this care very safely. And our publication, hopefully will be out for people to review, hopefully in the next week. But I really think that for us to be responsible is really to not be overly prescriptive when we bring out these guidelines and not tell people exactly what they can and what they cannot do, because it's going to be different depending where you are, what kind of practice setting you're in.
Well, I think you're exactly right.
Scott, I was just going to say I've defended a lot of doctors in lawsuits where guidelines are used against doctors, and so I think that's very important. So Scott, let's get your perspective on that, and then after Scott's answer, we'll go 10 more minutes for the panel before we close up.
Great. No, I think that you've hit it exactly right. I mean, the more specific the guidelines and the more room for a plaintiff's attorney to attack the practice based on not following the guidelines exactly, if the guidelines you recognize are imperfect. I mean, it takes a lot of guts to put the guidelines out there. It's great if Aspen to do it, but you do end up giving something, a tool for plaintiff's attorneys to use to show, well, this practice didn't follow, item number 33 of the guidelines, and thus they're, even though it might not have made no difference at all, it gives them something to hang their hat on in terms of bringing a suit.
Howard, any last thoughts on that?
No, I think those are all really good points. I just want to thank everyone for tuning in again, and Aspen will continue to, provide these webinars for the time being if the interest holds. Thank you, everyone. So
Scott, thanks so much for joining us. I think you're very valuable to our field, to the spine field, and the things you bring to the table are certainly very unique. So thank you again for coming, and we look forward to talking with you more in the future.
Well, thank you very much for having me. Tim, I'll drop off now if that's okay, if you'd like me to, but a pleasure to be on.
That's great. No, thank you very much. Christian, you want to talk about this next webinar on May 7th?
Yes. So we're going to actually, I think we've kind of led you guys from our first webinar, understanding what COVID is, to now kind of transitioning to getting your practice back into management. And then I think we're getting close to some part of the finish line to transition out of the COVID story to the kind of the more topic-based stuff. But I think one other one that has kind of, there's been a lot of interest from faculties really looking at cancer pain management in the era of COVID-19. So we put together a really nice panel that's going to be on the 7th of May. And really looking forward to hearing from different folks that have really been instrumental in taking care of cancer patients, and just seeing how they're kind of bringing that service back at this present point. And then Tim, do you want to, I think you and Dawood are going to be.
Yeah, we were involved in a study on stem cells in the disc last year. And so Dawood and I will moderate a panel looking at intradiscal biologics. And, certainly it could be the future of our field, or it could be dangerous. So Dawood, I see you joined us again. What's your thoughts on this panel?
Yeah, I think this is something that's, very intriguing to a lot of people out there. I'm still, kind of holding back and letting the experts tell me, when I should really proceed with this. So we've really assembled, which I think are really kind of the thought leaders, not just in the country, but in the globe on regenerative medicine. I think there's a lot of hokey regenerative medicine doctors out there, but we're really bringing people that are going to talk about this that are actually involved in the clinical studies and trials and real hardcore evidence and science. So I think this would really be really one of the more unique webinars that we host. Tim, you want to say a couple words about it?
Yeah, Tim, we got a couple other people online, so tell us about that.
Okay. Yeah, so I think you nailed it on the head. When you talk about regenerative medicine, there's all kinds of organizations and events that are being put on that are usually sponsored by some sort of company, and they're selling a product at that moment in time, and they want to drive their sales. With this, the group up there, and actually, somebody that should have been on there is Kaz Amber-Delphin, who is with us tonight. He's been on damn near every one of these interdiscal studies as well. And if there's still time, I'd actually like to add him onto that because he's got just a wealth of knowledge as well. But these are all FDA clinical trials that we've actually done over the past 12 to 13 years, and many of them have failed, right? Now we actually have 12-month evidence on an RCT of 226 people that actually has a positive outcome. And that's pretty amazing. That's pretty significant, especially with all the failures we've had. And the crazy thing is failures are not always failures. And anybody that's done enough research knows that you can have a product or a device or a treatment that actually works, but if it didn't supersede your control by a large enough margin, then it's not clinically significant. And one of the things we learned with the first 2 or 3 interdiscal studies we did is everything was randomized against saline. Well, as it turns out, saline is absolutely not a placebo in the disc. You get about a 40% responder rate. So what that did was that upped the bar on what success was going to have to mean for these other interdiscal products that we were injecting. And some of them just could not get enough of a delta off what saline had done. Yet, Doug Beal is going to be presenting some evidence that's pretty compelling. So I would encourage everybody to jump on that one.
So Tim, thank you so much. And Doug Beal, if you don't know Doug Beal, he's an interventional radiologist in Oklahoma who is one of the world's leading physicians in minimally invasive spine. So with that, Dawood, I want you to talk about this next slide, and we're going to close up.
Yeah, so we still hope, we're hopeful, fingers crossed, that we'll be able to have a medical conference in September. Don't watch too much CNN, watch a little bit more Fox. Maybe we'll probably be all there. We'll all be there in September. The Aspen Think Tank will be September 17, 2020. We'll have our annual meeting immediately following that, September 18th through 20th. And then another thing that we're really excited about launching then is the Young Guns Hands-On Cadaver Lab, and really focusing that on, we talked about it earlier, about this year's fellows that have lost a lot of hands-on time. So we hope that will help kind of make up some of that, giving them some hands-on cadaver time with some of the really innovative techniques and procedures taught by kind of the world's experts. Hope everyone can join us.
Great. Dawood, thank you so much. And thank you for all the things you're doing. Krishnan Chakravarthy, thanks for leading the COVID task force for Aspen. And thanks to all of our panelists tonight. Certainly wishing everyone the best. And we'll be in touch in a few weeks with the cancer pain webinar, the intradiscal webinar. We have a spinal cord stimulation webinar coming up. And at the end of the day, we're here for you, and we appreciate all that everyone's doing. So God bless and have a great night.
Thank you. Good night, all.